what I have to talk about are perioperative strategies for esophageal cancer. And yes, Viraj has added newer. So I think to begin with, this slide settles one debate, whether neoadjuvant or adjuvant. I think in the house we all agree that whenever possible in a T2 or N plus esophageal cancer, we will be going for an adjuvant. And there are particular reasons such as better tolerability of, we'll be going for neoadjuvant. And there are certain reasons such as better safety and tolerability in the neoadjuvant period. Downstaging R0 resection when you have a bulky disease. To treat microinvasive disease like we talk for breast cancer. One of the interesting thing is response adapted treatment. Those of us who treat breast cancer will realize we never thought that esophageal cancer can be treated in a response adapted way. And yes, the quantum and the solidarity of benefit in survival, overall survival advantage is definitely more in the neoadjuvant studies rather than adjuvant. Coming to the guidelines, yes, we all know that guidelines, this house does not need to be apprised of these guidelines that esophageal cancer, squamous, will be generally treated with a pre-operative chemoradiation. Adenocarcinoma or lower one-third will be treated with chemoradiation or a perioperative chemotherapy, something like a gastric cancer approach. And this has been adopted, and till date, this is still there in the ESMO as well as NCCN. And what extra has been added is the adjuvant immunotherapy, and we will come to it. Before 2018-19, we all know these were the landmark trials which decided how we treat esophageal as well as GE junction tumors. And whenever we treat with a perioperative chemotherapy approach, such as MAGIC protocols as well as FLOT protocols, we all know that stomach has been the major part of the clinical trials. When we talk about esophageal cancer, we talk about CROSS trial. And why do we talk about CROSS? Because that is one trial where maximum representation of esophageal cancers were there, as you can see on the slides. The delta in the term of overall survival, I'm not talking about response rates here or pathological CRs, is more or less same if we adopt a perioperative chemotherapy approach or a chemoradiation approach. Definitely the perioperative chemotherapy approach goes down to the lower esophagus as well as GE junction tumors. So this is what we used to treat, or this is how we are treating. Now what has happened new? Starting with new ages, this is a old age debate from last 5 years, that which is better, whether it is a MAGIC or FLOT is better or whether a CROSS is better. New ages was a phase 3 randomized trial. The primary endpoint of this trial was, the primary aim was to compare the pathological responses between perioperative chemotherapy approach, that is ECF or FLOT, versus chemoradiation, that is CROSS. It started with a superiority trial design, but they shifted to a non-inferiority trial design and kept the margin of 5% as the difference between the two arms. What happened in the recruitment during this time was that FLOT was not that popular among the oncologists, so only 27 patients out of I think 600 odd patients could enroll onto the FLOT. Rest everyone went into ECF. So practically this was a trial of a MAGIC versus CROSS and not FLOT versus CROSS, that is to be remembered. Coming to overall survival, that is similar, that settles the debate there, but coming to the responses. When you talk about the pathological responses, if you see there is a fourth from the column, there's a 5% pathological responses with MAGIC versus 16% with CROSS. And I'm sorry to put this red bar of a cross trial comparison that when we talk about FLOT, the pathological responses are 15%. So this is what is different is the response rates between the two regimens. Talking about the overall survival, there is not much difference. That is what Neo Ages taught us. But yes, there is a randomized trial between FLOT versus CROSS which is going on, and that is purely a FLOT versus CROSS trial regimen. So these are the conclusion of the authors. I will just run through it. The perioperative chemotherapy was not inferior to CROSS with 3-year overall survival similar. Markers of response, including pathological CRs, response rates, R0 rate, nodal downstaging, are significantly better with CROSS. No significant difference in severity of complications. So these are the conclusions of the authors of New Ages. Coming to Checkmate 577, again a newer thing which happened almost now 2 years. This was a response adapted trial which I talked about. Here, stage 2, stage 3, esophageal and GE junction tumors, adenocarcinoma or squamous, they were treated with chemoradiation. So they were treated like a cross-type regimen. And then they were randomized in a phase 3 trial to nivolumab for 1 year versus placebo. Primary endpoint is DFS and secondary endpoint is OS. Right now we have a median follow-up of 2 years. So the curve starts separating from 3 months. The tail of the curve is maintained, which is quite exciting to see for a malignancy like esophagus. A 10-month absolute DFS advantage with a hazard ratio of 0.7 definitely seems encouraging and practice changing. Delving deep into the trial and talking about subgroups, if you see the dotted line, it is the dotted line are the nivolumab. I mean, if the red and the blue, the nivolumab is showing more difference. If you see the dotted lines are for squamous cancer and the solid lines are for adenocarcinoma. So the gap between the curves for squamous cancer is much, much more. Among the Kaplan-Meier, going to the forest plot, hazard ratio is 0.75 for adenocarcinomas and 0.6 for squamous cell cancers. GE junction tumors were equally represented, 50% GE junction, 50% esophagus. Again, 0.6 is the hazard ratio for esophagus. GE junction, the hazard ratio is 0.87 and also crossing unity. So these are again hypothesis generating or to consider how to use it in your practice. Also, it was seen that PDL1 was a pre-stratified variable in this trial. PDL1 more than 50% showed much more better advantage as compared to PDL1 less than 5%. So this is what we learned from Checkmate 577, that yes, response adapted therapy definitely changes practice, and you can use response adapted therapy based on this trial, that which can be the best subset in your practice. But yes, if we talk about the approvals, there is a blanket approval to use nivolumab for 1 year in all those patients who have been subjected to new adjuvant chemoradiation. Whether we can extrapolate this to someone who is going on magic and flot and not achieving pathological CR is not yet known to the scientific community. Now, when we always talk about immunotherapy, the recent excitement which is all over the social media is about using it in the non-metastatic settings. The one example was in the adjuvant setting. Whether we can bring it in the peri-operative settings, that will be quite exciting. And why I have put this slide here is that whenever we talk about microstabilite instability, we always know that MSI positive patients will not respond well to chemotherapy, and primarily they don't do well on a 5-FU metabolite. Also, anyone who has an MSI will do well because they will keep on responding to the platinum salt of therapies as well as to immunotherapies, and their survival is better. What is to be remembered is the left-hand slide. I do admit that this is primarily a gastric cancer data, but the 9% in this IPD meta-analysis, only 9% are esophageal, which is the primary topic of the of the discussion here. If you talk about the right-hand slide, you see in a surgery versus chemotherapy arm, the left, that is this A or B. The A is the DFS and the B is the overall survival. There is a misprint, that is an overall survival. The difference is quite less if you see in the MSI high patient, thus suggesting that whether chemotherapy is the right approach. Based on this hypothesis and this database, this was a trial which was recently published. It is called JERCOR. The JERCOR is the group, and NEON-PIGA, that is new adjuvant nivolumab, ipilimumab in the esophageal and gastric cancer. That's the name is a tongue twister. Yes, I do agree this is a phase 2 study. I do agree that the patients are only 32, and this is not a practice-changing trial, but it definitely, as Kothari sir said, that it excites you. Yes, this excites you and thinks how we can treat separately. I will tell you the design of the trial. The design of the trial was 6 cycles of nivolumab were given every 15 days. That makes it 3 months of nivolumab with 2 doses of ipilimumab at 6 weeks apart. This was the new adjuvant therapy. Patient underwent surgery, and then after that they are receiving adjuvant only nivolumab for 9 doses. So total 9 and 6, around 15 cycles of nivolumab has gone. A perioperative therapy, no chemotherapy in this trial. and total duration of treatment is around 1 year. Coming to the results, the primary endpoint what they wanted to study was the pathological CR. 29 out of 32 patients underwent surgery, just to allay the anxiety of the surgeons, and one had met and two refused for surgery. It was not that they were made ineligible for surgery by giving immunotherapy. 58.6% response rates. One post-operative complication was there in 16 patients. If you see the swimmer's plot, TRG1A is pathological CR. That is the black diamond on the slide. And you can see there are so many black diamonds, and many of them are able to go to the adjuvant nivolumab, that is the orange bars. On the right-hand side, yes, only 25-30 patients, but you can see the curve, absolute flat line. Yes, I wish that this flat line persists, because the follow-up is, I think, 14 months in this trial, which is a bit less. But the DFS as well as OS of this 28-29 patients is having an absolute flat line of 14 months. These are the conclusions, and the presentation slide is not mine. This is from GI ASCO 22 session. I will go with the verbatim fast. Primary objective with 59% PAS CR was met. Neoadjuvant NIPI-IPI is feasible in MSI resectable G junction as well as gastric adenocarcinomas. No new safety concerns. 25% grade 3, grade 4 adverse events. Surgical complications are as expected. 94% of the patients included are free of events with 12 months follow-up. And this raises the question whether surgery can be delayed or avoided. This is a bold statement. Whether surgery can be delayed or avoided for some patients with localized MSI high esophageal or G junction carcinoma. And I think this, making this statement, the authors had something in mind that they could make such type of statements on an international platform, and that's why I put this slide as verbatim. I will just rush through HER2. Yes, something has happened in HER2 also. This is HER2 FLOT, where we give FLOT type of regimen and combine trastuzumab. This is a phase 2 single-arm trial, 50 patients trial. Median DFS at 36 months of follow-up is around, median DFS is 42 months, and 3-year overall survival is 82%, which is quite exciting. We also have Petracia study. This was, I think, in ESMO 2020 or ASCO 2020. Both, it was presented in both the forums. Here, the esophageal adenocarcinomas have been, the first arm is FLOT. The second arm is, a perioperative FLOT, 4 cycles FLOT surgery, 4 cycles FLOT. And trastuzumab and pertuzumab, dual HER2 therapy has been combined. Primarily, they were looking at pathological CR, but also the disease-free survival data is there. There is a big difference between pathological CR, 12 versus 36%. So as far as the response rates are there in the primary endpoint of the phase 2 trial, that has been met. But as far as the disease-free survival, the primary, the median DFS is 26 months in FLOT and not reached in FLOT plus trastuzumab, pertuzumab, amounting to a hazard ratio of 0.57. So I think we will look for this space in the future, that whether it actually amounts to adding trastuzumab, pertuzumab, or only trastuzumab in the perioperative settings, how much DFS and OS advantage we will give is the space to be watched for. Yes, we all know that trastuzumab deruxtecan has been showing very good results, and I think in another 5 years, we will have that molecule also in the perioperative settings. Though till date, there is no trial which is out showing that data. I will skip through this in the interest of time, and we generally don't practice. I will just, if the patient has been subjected to the therapy adjuvant, usually we tend for surveillance. Anyone who has a margin positive or node positive can go for CTRT, which is not a standard of care, and that can be decided on a case-to-case basis regarding the adjuvant therapy. Coming to the last slide, one of the more exciting ones, what will happen in next 2 years or more? Yes, another 2 years we will have these results out. We already are having advances, and gradually robotic assisted minimally invasive surgery is becoming one of the standards, and more data and experience of the surgeons across the world is coming. I was talking about ESOPEC. ESOPEC is exactly a FLOT versus cross, and that is what we all want the answer. The trial results, I will just need another 10-15 seconds. The phase 3 randomized 400 patients trial. The trial results will be out, I think, in 2023. Top Gear is again a flawed perioperative regimen, but in the other arm, that is the experimental arm, they have added chemoradiation with cisplatin 5-FU as one cycle. All these are trials ongoing. Palace 2 is actually a cross regimen, chemoradiation, and pembrolizumab has been added to it, and then the patients have underwent surgery. And yes, there was a recent, this is just in the abstract form that I think this was AACR, April 2022. This is just a snapshot from the web where pathological CRs have been increased when pembrolizumab has been added to chemotherapy in the perioperative setting. So these all are the space to be watched for. These are not to be adopted on Monday morning. But I think it will be quite exciting to see how the Jercor, Neonpiga, as well as Palace and perioperative regimens, how does the immunotherapy do? And I think we eagerly wait for ESOPEC so that our debate settles versus cross versus flawed. Thank you for patient hearing.